Hello, I am Dr. Rajiv, an ICU consultant. Many families ask me, Doctor, why does one patient have a tight mask and another has a tube and a ventilator? In this video, I will explain in simple language how we decide between a breathing mask and putting a tube into the windpipe. My aim is to reduce some of the fear and confusion around these decisions so that you understand what's happening to your loved one. In the intensive care unit, we mainly use two types of respiratory support. The first is a non-invasive ventilator, which means a tight mask on the face connected to a machine. The second is an invasive ventilator, which means a tube into the windpipe connected to a ventilator. Both are used to support the lungs when the body is struggling to breathe, but they are used in different scenarios and they carry different risks and benefits. Let's start with non-invasive ventilator, often called BiPAP or CPAP. This tight mask that covers the nose or nose and mouth. The mask is attached to a machine that pushes air in with pressure to help the patient's own breathing. The important point is there's no tube inside the throat. The patient is still breathing through their own airway and the machine is assisting them. We usually use this when the patient is awake, is able to follow instructions, and is able to protect their own airway. That means that they can cough, swallow, and if needed, call for help. Non-invasive ventilation can be very useful in conditions like flare-up of COPD, some types of heart failure, where fluid is backing up into the lungs, or in some patients whose lungs are tired but still coping. It can reduce the work of breathing, improve oxygen and carbon dioxide levels, and sometimes helps us avoid putting in a tube. One big advantage is that if it works well, we can remove the mask and bring the patient back to normal breathing more easily than taking them off the ventilator. Now let's talk about intubation and invasive ventilation. Here we place a tube through the mouth into the windpipe or use an existing tracheostomy tube in the neck and connect this tube to a ventilator. Then the machine takes over a large part of work of breathing. This is a more aggressive form of support. We use this when the patient is too sick and can't breathe safely on their own, or when the non-invasive methods are not enough. We consider putting a tube when the patient is very drowsy or confused or cannot protect their airway, or when they cannot cough properly, or when they are at high risk of inhaling their vomit or secretions into the lungs too. We also move to intubation even with the tight mask and high support. The oxygen levels stay low or the breathing muscles are clearly getting exhausted. In situations of very low blood pressure, severe shock or cardiac arrest, the tube and the ventilator are often needed to stabilize the patient and give us time to treat the underlying problem. So when do we try the mask first? We usually do that when the breathing is clearly worse than normal, but the patient is still alert, able to talk in short sentences, and able to cooperate with the mask. In conditions like COPD flare-ups or some heart-related breathlessness, a trial of non-invasive ventilator can be very, very effective. The goal here is simple: support the lungs, decrease the work of breathing, and hopefully avoid the tube and its complications. On the other hand, there are times when going straight through a tube is the safer option. If someone is not fully conscious, is repeatedly vomiting, cannot swallow or manage their saliva, or is having very fast, shallow breaths, a mask is often not enough and can even be dangerous in those situations. In those cases, delaying intubation and just trying the mask a little bit longer can lead to a crash situation where we are forced to put the tube in during a collapse, which is way more riskier than for the patient. This is why timing matters so much. Waiting too long on a mask when it's clearly not helping can put the patient at more risk. But intubating too early has its own downsides, such as the need for sedatives and the risk of infection. In the intensive care unit, we keep reassessing the patient repeatedly. Their breathing rate, oxygen levels, blood gases, mental state, and blood pressure, and various other parameters. Based on all of this, a decision is made whether to continue with the mask, escalate the support, or move to a tube. It's not a single decision at one point of time, but it's a continuous dynamic process. For families, it may look like we're changing plans a lot, but that's because the patient's condition is changing and we need to change with it. We must respond to those changes quickly. It is never about convenience for the staff. It is always about the safety of the patient. If your relative is on breathing support, you can ask simple and useful questions like, what is the goal with the mask right now? What would make you decide to put a tube? This helps you understand what the team is watching for and what the next steps could be. Every patient is different, and decision between a mask and a tube is always based on safety and not on giving up. If your relative is on breathing support, you can always ask the ICU team what the current plan is and what could change that plan. I hope this video made that decision-making process clearer for you and helped you feel a little less afraid of these machines and masks that we use to support your loved one. If you like this video, please share it with somebody who may need this or who may find this helpful. If you like this video, please feel free to like, subscribe to our channel. Thank you for watching.